everyone. Good afternoon and welcome to this session of Last Resort Revision by me, Dr. Vyshnavi, and I'm your ENT faculty, and we are going to begin this last resort revision for INI-CET. So before we start the session, let me know if all the audio visual, relay is fine at your end so that we could start with the class. If it's fine, just give me a thumbs up in the comment section below so that we could start. Good afternoon, Javed. I hope it's all fine. Yes. Thank you so much for the confirmation and let's begin the class. So initially I'll be doing few MCQs which are going to be clinical based. Some of them are going to be previous year's questions. And then we are going to do a quick revision through the help of some images. And then we are going to do some instruments and we're going to do some signs which are commonly asked. So this would be comprehensively covering all the topics. We'll be covering the important signs. We'll be covering important images that could be potentially asked, and we are going to cover all the instruments which are important for your INI-CET as well. Yes. So good afternoon, Alia, Nikki, Mahesh. Good afternoon, everyone. So let's begin the session. We'll start off with an easy question where we have a 32-year-old female presenting to the clinic with complaint of unwanted movement on one side of her face. She says that the right side of her face will randomly twitch without any inciting factor. An MRI shows a prominent vessel intruding in her internal auditory canal. The nerve affected by the vessel causing symptoms is found in which quadrants in the fundus of the internal auditory canal? So this is a very simple question. They're asking you that there is a patient who's having unwanted twitching movements of the face. So this is caused by which nerve is first you have to understand, and where does this nerve lie in the internal auditory canal is the second part of the question. So let me know your answers in the chat box so that I know that all of you are actively participating through this entire session. Yes, so if we take the internal auditory canal, we have got a vertical crest of bone which comes from above, and this vertical crest of bone is called as Bill's bar. What is it called as? Bill's bar. And then we have got a horizontal crest of bone which is called as falciform crest. In the antero-superior quadrant, we have got the facial nerve. In the antero-inferior quadrant, we have the cochlear nerve. And have we all read this before that in the anterior quadrant, 7 up and coke down? Yes. So now we are very sure that the seventh nerve is in question because they're telling to you that the nerve is causing involuntary movements of the face, which means that the nerve in question is your facial nerve. And where is it lying? In the antero-superior quadrant. What lies in the antero-inferior quadrant? It is going to be your cochlear nerve. In the posterior-superior quadrant would be your superior vestibular nerve, and posterior-inferior quadrant would be your inferior vestibular nerve. So this comprehensively covers the anatomy of internal auditory canal with the help of a clinical MCQ. Now let's go to the second question where we have a 53-year-old female presenting to the physician because of headaches and pulsatile tinnitus. So whenever you hear the word pulsatile tinnitus, something has to strike in your brain. Even before you go ahead with the rest of the question, pulsatile tinnitus is diagnostic. It is hallmark of one very important condition, right? What is that condition? We know that glomus tumors present to you with pulsatile tinnitus. Correct. All of you have already answered that. Very good. Now the patient undergoes a gadolinium enhanced MRI and it shows a right-sided jugular foramen paraganglioma with vivid contrast enhancement, which is expected. So we know it's a glomus tumors are paragangliomas and they are vascular, so they take up contrast. Which of the following will be the likely otoscopic finding is the question. Will you see a normal tympanic membrane? Will you see a perforation of the tympanic membrane? Will you see a pulsatile red mass behind the tympanic membrane? Or would you see an isolated right tympanic membrane hypervascularity? So now that you're able to comprehend the question where you know that the pulsatile tinnitus is suggestive to you of glomus, and we know glomus secrete what? They secrete catecholamines. And because of catecholamine excess, can we have headache, tachycardia, palpitation, and symptoms of sympathetic excess? Yes. Now they are telling to you indirectly it is glomus by telling that it is a paraganglioma. They haven't given out the word glomus, but they have given you paraganglioma, suggesting it's a glomus tumor. In glomus, what is the clinical sign that we see? We see that there is a pulsatile red mass lying behind the tympanic membrane, and this appearance we call it as rising sun appearance. Can I also call it as a sunset appearance? Yes. So don't get confused in the exam. Is it rising sun or sunset? They are the same. What are the other two clinical signs we see in glomus tumor? We see brown sign and we see aquinose sign. What is brown sign? Whenever we put a Siegel's pneumatic speculum and we increase the pressure in the canal, the tumor vibrates vigorously and then becomes pale, which is called as brown sign. Compression of the carotid makes the tumor pale. That sign we call it as aquinose sign. So if you see, all these three are your clinical sign. Can you all tell me which are the two radiological signs in the chat box quickly? Because this will cover all the signs of glomus tumor. So what are the two radiological signs? One you see on a contrast enhanced CT scan and one you see on an MRI. So clinical signs we've all understood. What are the two radiological signs? Yes, very good. It is Phelps sign that we see in the CT, where we see that there is erosion of the bone between the carotid and jugular, which is right. Most of you have answered. Himanshu, you're absolutely right. Alia, you're absolutely right. On MRI, we see an appearance which is called as salt and pepper appearance. Very, very good. And in glomus, we know what are the contraindications: no FNAC, no biopsy, no probe test, no digital palpation. What is the investigation of choice? CECT is the investigation of choice. Will you do angiography? Yes, to identify the feeding vessel. And what will be the treatment of glomus tumor? Embolization followed by surgical excision. So this comprehensively covers the entire symptom, signs, radiological signs, diagnosis, and treatment of glomus tumor. So that chapter is done in 2 minutes. Now let's go to the next question. Which of the following is the best method for determining appropriate duration of antibiotic treatment for malignant otitis externa? Very, very important question in malignant otitis externa is related to the signs that we see and in terms of diagnostic tests that we do for MOE. These are the two areas that can be constantly tested in your exam. So can you tell me what is the answer for this? So they're asking you, when do you stop? What is the appropriate duration of antibiotic? Which means for resolution of disease, what scan will you do? So I see some of you are split here, some of you are answering 3 and some of you are answering 4. So whenever we talk of malignant otitis externa, there are two radionucleotide scans that we do. The first one is called as Technetium-99 scan and the second one is called as Gallium-67 scan. Now Technetium is taken up by both osteoclast and osteoblast. So whenever there is an osteoclastic activity happening in the initial part of the disease, we see that there is some osteoclastic activity. So in the early diagnosis, what scan will help me? It will be your Technetium-99. Whereas Gallium-67 is taken up by neutrophils. Neutrophils are cells of acute inflammation, and once you have given treatment, appropriate antibiotic treatment is done, neutrophils will disappear, which means that this scan which was positive will become negative. So this will tell me the when to stop the therapy or the prognosis of the disease is told by Gallium-67. If I ask you what is the investigation of choice for malignant otitis externa, it will be a plain CT, non-contrast CT scan. Is there a role of MRI? Yes, only if there is any intracranial extension. Now the questions that comes to you on malignant otitis externa, can you tell me what is the organism responsible for causing malignant otitis externa? Can you all tell me what is the main sign that the patient will present to you, which you see on examination? And I want you to tell me exactly in malignant otitis externa, what is the treatment? Yes, it is Pseudomonas, that is the organism that is responsible for causing it. On examination, what do you see? On examination, we are going to see granulation tissue where at the bony cartilaginous junction, this is the hallmark of the disease. Yes, antibiotics could be anti-pseudomonal antibiotics like piperacillin, ticaracillin, those are the drugs of choice. Along with that, third generation cephalosporins also can be given, and aminoglycosides may be added in certain cases. If I ask you which nerve is the first nerve to be involved, most common nerve to be involved in the disease, see, it can involve almost all the cranial nerves when it erodes the base of the skull, but which is that one important cranial nerve that is involved in the disease? Very, very good. It is your facial nerve. Thank you. You're all are responding very well in the chat box. I'm more than happy to take discussion up forward like this. And with this, we have revised the important concepts of malignant otitis externa. How do we diagnose? How do we treat? What are the signs? Is all done. Now, can we all discuss the next question, which is what is the method of speech communication after laryngectomy? All of them are included except a very simple question, but a common repeat question, because we see this as an image-based question. We see this as a clinical MCQ. We can be given this question in various formats. So quickly answer in the chat box. Yes, I'm waiting for your answers. See, all of them are used like electrolarynx, esophageal speech, tracheoesophageal speech, but what is not used is the tracheal speech. So tracheal speech is not something that we use in communication after laryngectomy. So this was a very simple one. Can you all identify the muscle that is shown here? The muscle that is lying on the extrinsic surface of the larynx, having two bellies. What is this muscle? Yes. What is the function of this muscle? See, this is definitely your cricothyroid, because this is the only muscle having two bellies. This is the only muscle lying on the extrinsic surface of the larynx, and only muscle supplied by external branch of superior laryngeal nerve, because all the other muscles are supplied by recurrent laryngeal nerve. So the function of this muscle is that it is a tensor of the vocal cord. And since it is a tensor of the vocal cord, what is it responsible for? It is responsible for phonation. Can you all tell me what is the muscle responsible for respiration, which is the only abductor of the vocal cord? The only abductor of the vocal cord is, very good, all of you are answering this right. It is your posterior cricoarytenoid. Very good, Nirmal. Very good, medical 3. So this is correct. It is your posterior cricoarytenoid. Right? So this is done. Now let's go to the next question. In cholesteatomas, most bone reabsorption occurs because of pressure. Is it because of action of osteoblast, action of osteoclast, action of alkaline phosphatase? What is the cause in cholesteatomas? See, in cholesteatoma, we know that there is a skin in wrong place. What is skin in wrong place? There is presence of stratified squamous epithelium in the middle ear. Middle ear is normally going to have cuboidal epithelium, but if there is a stratified squamous epithelium in the middle ear, then we say that it is cholesteatoma. These cholesteatomas we know are unsafe because they erode. How do they erode? By producing some enzymes. What are those enzymes? It is collagenase, acid phosphatase, alkaline phosphatase, and other proteolytic enzyme. Because they produce these enzymes, they are going to cause destruction. So is it because of pressure, osteoblast, osteoclastic activity, or is it because of enzymatic degradation? It is because of enzymatic degradation, it is going to spread. So I see most of you have gone wrong in this particular question, but most cholesteatomas are going to spread because of enzymatic degradation. It is not because of pressure, not because of osteoclast or osteoblastic activity. Now, if I ask you what is the most common site of origin, go on answering in the chat box for cholesteatoma. What is the most common ossicle to be involved in cholesteatoma? What is the most common site of spread? And what is the most common site of recurrence? And I want to know what is the investigation of choice and what is the treatment. Yes, very good. The most common site of origin is Prusac space. And where is the Prusac space? It's the space between pars flaccida and the neck of malleus. The most common ossicle to be eroded is going to be the long process. If they ask you specifically which part of the long process, then you can answer lenticular process. But it is the, you can in general say the long process of the incus. What is the most common site of spread? It is across which canal? Lateral semicircular canal. And what is the most common site of recurrence? It is the sinus tympani. What is sinus tympani? Is it a suprapyramidal space or an infrapyramidal space? It is an infrapyramidal space. The investigation of choice for diagnosing cholesteatoma is going to be a plain CT, a non-contrast CT scan. And the treatment is there is no role of medical therapy. You will do surgery, which is modified radical mastoidectomy. Correct? Yes, high resolution CT scan, non-contrast CT scan is the right answer. I agree with all of you. The treatment is surgical, which is modified radical mastoidectomy. So all of you have understood this? Okay, now let's go to the next question. The investigation shown in this particular image is what? It is used in the diagnosis of otosclerosis, Meniere's disease, acoustic neuroma, or facial nerve pathology. Susugamushi, HRCT, non-contrast CT is the same. No problem. That is the right answer. If HRCT is given, high resolution CT scan is the right answer. Non-contrast CT is given, that is also the right answer. Okay. Yes, so here we are seeing that through the tympanic membrane, an electrode is placed over the promontory, which is the basal turn of cochlea. And this is recording the electrical activity that is happening on giving an acoustic stimulus. So whenever you see transtympanically an electrode is kept and that is recording the electrical activity, the investigation is called as electrocochleography. So what is it called as? This is your electrocochleography. Normally, the SP by AP ratio should be less than 30%. But if the SP by AP ratio is more than 30% or 0.3, then the diagnosis is going to be Meniere's disease. So the answer here is going to be Meniere's disease. Right? For otosclerosis, can you tell me what will tell you that it is otosclerosis? What is your investigation of choice? For acoustic neuroma, what is the investigation of choice? Quickly. See, sometimes they can give you 45 also as a number in Meniere's disease. That is also acceptable. If they give you more than 45%, that's also right. Okay. So in otosclerosis, the history, the examination are quite diagnostic of, otosclerosis. But if they ask you the investigation of choice, then it has to be tympanometry. On tympanometry, what type of graph will you get? An AS type of graph. So if you get this AS type of graph, then it is suggestive to you of otosclerosis, right? PTA audiometry can show Carhart's notch in some patients, but not all patients. But if it is AS, then it is indicating to you sclerosis. Okay. For acoustic neuroma, the investigation of choice is a gadolinium enhanced MRI or a contrast enhanced MRI, which is the investigation of choice, which will show us what appearance? Ice cream cone appearance. Right? So that's about it. Let's go to the next question. The structure pointed in the image represents. So basically, they're trying to identify what is this structure that you see here. Is it lateral canal? Is it the superior canal? Is it the facial nerve or is it the sigmoid sinus? So I can zoom in a bit for all of you to help you understand this. So this is your external auditory canal leading to the tympanic membrane. This entire is your mastoid cavity where we have done a mastoidectomy. The canal that you see here is your lateral semicircular canal. What is this communication between the antrum and the attic? Attic is the roof of the middle ear. What will this communication be? Yes, this is going to be your Aditus. Can you all tell me what is this bluish bulge here? This bluish bulge that you see here? It is formed by which sinus? Yes, it is formed by the sigmoid sinus. The roof of the mastoid is formed by a thin plate of bone. What is this thin plate of bone called as? Tegmen. What is this angle that is present here between the tegmen and the sigmoid? Between the dural plate and the sinus plate. We call this as sinodural angle, also called as tegmen tympani is the roof of the middle ear and tegmen mastoideum is the roof of mastoid. Both of them are continuous. So this would be tegmen tympani. This is your tegmen mastoideum. Got it? Yes. So sinodural angle is also called as Sittelli's angle. Okay. So if you see this posterior canal wall is present and it has not been removed by surgery, then we say that it is a canal wall upsurgery or cortical mastoidectomy. But if this posterior canal wall is removed, then we say it's a canal wall down or a modified radical mastoidectomy. So now we know the structure that has been marked, which was in question, was this one, and it is your lateral semicircular canal. Facial nerve, if it had to be, would be along the posterior canal wall. You would have seen it here. This would be the vertical segment of the facial nerve. So you would have seen it like this. Got it? So I think all of you are clear with this. The image shown is associated with myocarditis, bronchiectasis, sinusitis, both 2 and 3. What is your answer? You see that there is a mass of dead squamous epithelium that has occupied the external auditory canal, forming one layer over that another layer over another layer, forming an onion peel appearance, presenting to you with ear pain and a blocked sensation resulting in conductive hearing loss. What is it? It is keratosis obturans. So keratosis obturans is a condition where the dead epithelium of the canal gets piled up and accumulated. It is because of the ciliary defect that is there in the external auditory canal. So normally the cilia will beat the epithelium onto the outside, but if the cilia start to accumulate the epithelium one layer over another layer over another layer because they are not functioning well, it will result in keratosis. So which are the conditions which are associated with ciliary motility disorders? It is going to be your bronchiectasis and sinusitis. So the answer is going to be both 2 and 3. Right. Now let's see what are the structures seen on anterior rhinoscopy are all except. So you're seeing that there is an image-based question where you can see the structures which we see normally with anterior rhinoscopy. What we cannot see is your question. Internal nasal valve, inferior turbinate, middle turbinate, or superior turbinate. Very good. I can see some of you have already started to answer. It is 3, which is the right answer. So we can see this is the area of the internal nasal valve. Right? What is this turbinate here? This is your inferior turbinate. This turbinate here is your middle turbinate. We cannot see the superior turbinate. And what we see here, this one is your nasal septum. Correct? Yes. So these are the structures which we see on anterior rhinoscopy, and the instrument that is used to do this is called as Tudicum's nasal speculum. Sometimes we can use another speculum which is called as Killian's nasal speculum, but the commonly one that we use is Tudicum's nasal speculum. So I hope this is done. Now let's go to the next question. All are true about the following condition except. So they have given you an image-based question and asking you that all of the following about this particular investigation is true except. Can it cause caloric reaction? The direction of jet is straight towards the tympanic membrane, contraindicated in perforation of the tympanic membrane, none of the above. So what we are seeing here is a caloric test, and when we are doing a caloric test, what are we trying to do? Or syringing. Say what we are trying to do is syringing or caloric test, one of the two. We are putting water in the exploratory canal and we're doing this test. So particularly here, we are seeing some waxes coming out. So it is syringing and not caloric test. So can it cause caloric reaction? Yes, it can cause caloric reaction where hot or cold water can induce nystagmus. So you have to use water which is of our body's temperature, which is 37 degrees centigrade. So can it cause caloric reaction if you use warm water or cold water, inducing nystagmus and vertigo? Yes. Direction of jet is straight towards the tympanic membrane is wrong. The direction of jet is towards the posterior wall of external auditory canal. Is this contraindicated in tympanic membrane perforation? Yes. So what is not done or which of the following is wrong is option 2, and which all of you have answered. So Shiv Kumar, if you're asking me, is LRR sufficient? So LRR basically is a comprehensive revision of the main content. It doesn't replace the entire main videos or the rapid revision videos. If you're confident about the subject, then LRR should be a good revision for you before you go to the exam, because we comprehensively touch all the PYQs and PYTs when we're doing this LRR. True about this condition. So you're seeing that there is a bulge here in the external auditory canal. You can see some hair also. So where are we? You think about it. What is true? Is it staphylococcal infection the most common cause? Repeated such infection must prompt the clinician to look for diabetes. Tragal sinus positive, all of the above. Yes, I see all of you are answering this right. So all of the above is the right answer. So we are in the cartilaginous portion of the external auditory canal. How do I know I'm in the cartilaginous portion? Because we are at the level of hair follicles, and staphylococcal infection of the hair follicle, what do we call it as? Furunculosis, also called as folliculitis. And whenever there is a furuncle, if there are repeated furunculosis, you should look for underlying immunosuppression or diabetes. And in these patients, when you compress on the tragus, the patient will wince with pain. So tragal sign will be positive. So all of the above is the right answer. Okay, let's go to the next question. A patient with facial injuries is brought to the casualty with swelling of the upper lip and bleeding from the nose. There is malocclusion and ecchymosis of the maxillary buccal sulcus. See the word maxillary buccal sulcus. There is a bilateral transverse fracture going through the maxilla above the teeth. So which type of fracture, which is called as transverse, which is called as pyramidal, which is called as craniofacial disjunction in Leaford? Yes, very, very good. So we all of you are right. Leafort one fracture. Some of you have written two, Himanshu and Mahesh and Mamta. Leafort two fracture is pyramidal fracture, right? So if I take this as the face and if I draw the fracture line, the fracture that runs from the floor of the nose and floor of the maxillary sinus, which is transverse. What will I call this as? Leafort one fracture, maxillary buccal. So this is your maxilla, this is your buccal. So there is a fracture at the maxillary buccal sulcus. What is Leafort two fracture? It starts from the nasion medial wall of the orbit and goes to the maxilla. This type of a pyramidal fracture, we call it as Leafort two fracture. And what is Leafort three fracture? Craniofacial disjunction, where the cranial cavity is separated from the facial skeleton. That we call it as Leafort 3. So the question is asking you transverse, not pyramidal. Pyramidal would be type 2. Type 3 is craniofacial disjunction. There is no Leafort 4 fracture. Correct? Yes. So if I ask you in Leafort 4, Leafort 1, 2 or 3 fracture, where would you get hanging palate and hanging teeth? This is seen in which fracture? Go on answering in the chat box quickly. Where would you get hanging maxilla? Where would you get high risk of CSF leak? Hello, Radha. Thank you for that message. Chala chala, thank you. And I am so happy that मेरे FMG pass ayaru. Wishing you the best for INI-CET and NEET PG. Yes. The highest risk of CSF leak is in Leafort 3 fracture. Hanging maxilla, hanging palate is seen in Leafort 1. Hanging maxilla is seen in Leafort 2. Correct? Yes, so this is about Lefort's fracture and the maxillary fractures, right? Now let's go to the image. The image is showing to you which space. So this is the image that is pointed out. This image is showing to you parapharyngeal space, retropharyngeal space, danger space, or prevertebral space. To be very specific, the space marked in yellow. If I ask you, the one marked in yellow is which space? Not the green one. So if we see this space, it has got two fascia. The one anteriorly, it is called as buccopharyngeal fascia. The one that is present posteriorly, this fascia is called as your prevertebral fascia. Correct? So between your buccopharyngeal fascia and your prevertebral fascia lies your retropharyngeal space. Now this is divided into two compartments by another fascia. What is this fascia dividing it into two compartments? This fascia is called as alar fascia. Correct? The anterior compartment, which is in yellow, is your true retropharyngeal space. Very, very good. All of you are answering it very well. The posterior compartment is called as danger space. Perfect. So the image that is showing to you is your true retropharyngeal space. Now, true retropharyngeal, other name for this true retropharyngeal space, can you all tell me? What is the other name? Posterior space is danger space. What is the other name for true retropharyngeal space? It contains a node which is called as node of dash. Source of infection in this space is dash, and such an infection will cause acute retropharyngeal abscess, which is common in adults or children. So give me answers for all of this. Yes, true retropharyngeal space is called as space of Gillette. What is the node that is present there? Very, very good. All of you are right. Mamta, you're good, right? It is called as node of Rouvier. The source of this infection is usually adenoid and tonsil that will cause. So it is tonsil or adenoid infection. And whenever there's a tonsil or adenoid infection, it can go to this node, causing saturation of the node to result in acute retropharyngeal abscess. And this is commonly seen in children. What is the source of infection in danger space? Danger space, the source of infection is tuberculosis of spine, and this will cause a chronic retropharyngeal abscess, which is commonly seen in adults, right? And last one question, where does the true retropharyngeal space end? It ends at 4th thoracic vertebra. And where does the danger space end? The danger space ends at the level of diaphragm. Done. So that's about your retropharyngeal space and retropharyngeal abscesses. So I hope all of you have got this. Now let us go about this MCQ. Identify the condition which of the following is false. It is caused by HPV. It may present to you with stridor and hoarseness. It should be left untreated as it is self-limiting. It may cause complete airway obstruction, and it is usually acquired from mother. So I'm waiting for all of you to answer. Yes, all of you are right. All of you are answering it right. The condition that you see here is juvenile onset recurrent respiratory papillomatosis. Why am I saying it is juvenile onset recurrent respiratory papillomatosis? Why not adult onset? Because adult onset will have single papilloma, not multiple papillomas. Here you can see there are not one, there are multiple papillomas involving multiple subsets of the larynx, whereas adult papillomas are single. Juvenile is transmitted from mother to child via vaginal birth. So this is true. Whereas adult onset papillomas occur because of sexual transmission. Is both of them caused by HPV? Yes, both of them are caused by HPV 6 and 18, which are the common HPV variants. 11 also can cause in some patients. Can they present to you with hoarseness and stridor because they're occurring on the glottis, on the vocal cords? There can be change in voice, and eventually when they grow completely, they can block the airway to cause stridor. So can they cause airway obstruction? True. But should you leave it untreated? Of course not. You have to treat it. And what is the treatment? You have to do surgery. And the surgery, the instrument that is used. See, initially we would say laser assisted resection, but now we don't say laser assisted resection. It is micro debrider assisted resection. Yes. I hope all of you have got it. Micro debrider. This word has to be used or will be given. Microlaryngeal surgery is done for removing this papilloma. So all of you have got this? Yes. So I'm sure with the revision is done of juvenile onset, adult onset, which one is caused by what and how they present to you is all done. Now, can you identify the space marked in the diagram? So can you all see here? There is an image that is marked and they're asking you, is this pre-epiglottic space? Is this paraglottic space? Is this Rinke space or is this the true space of the larynx? This is the image and this is the space. So medical 3, it is not Rinke space. Rinke space is in the vocal cord. This space is on the side of the vocal cord. What is Rinke space? In the vocal cord, we have 4 layers. So when I take this as the vocal cord, the medial most layer is your epithelium. Then we have got the superficial lamina propria, then we have got the vocal ligament, and then we have the vocalis muscle. So the space between the epithelium and superficial lamina propria of the vocal cord, we call this space as Rinke space. So have they pointed the vocal cord and asked you the space? No. So that is why it is not Rinke space. There is nothing called as true space of larynx. We have got a pre-epiglottic space and paraglottic space. So pre-epiglottic space is here, which is in the midline, whereas paraglottic spaces are located on the sides of the vocal cord. So the image is showing to you the paraglottic space of Tucker. Pre-epiglottic space is the one that you would see here in the midline. So that's right. All of you have given me the right answer. The paraglottic space of Tucker is the right answer for this question. What is this CT scan pathognomic of? You see here? What is this CT scan showing to you? As soon as you see this scan, your diagnosis should be fixed in the mind. What is the diagnosis that we're discussing here? You're seeing that there are areas which are light gray and areas which are dark gray. Can you tell me what are these? There are 2 different densities. Yes, heterogeneous or double densities is a feature of, I'm waiting for your answer. Allergic fungal rhinosinusitis, AFRS, allergic fungal rhinosinusitis. It is an invasive or non-invasive infection. It is a non-invasive fungal infection that is caused by aspergillus. We'll learn more about it, the Bent and Kuhn's criteria. There's an MCQ, but we'll just go to the next MCQ at the moment. After RTA, there is a patient who's brought to the ER and he has hit the head on the steering of the car. So there's a trauma, and after trauma, there is a clear mucus draining, meaning clear watery nasal discharge. On CT, there is a fracture. What is the most likely anatomical injury caused by this symptom? So when there is clear fluid after trauma, there is a fracture. We are thinking of what? We are thinking of CSF rhinorrhea. And in CSF rhinorrhea, what is the most common anatomical site of injury where there could be CSF leak from? Yes, it is from the cribriform plate of the ethmoid, which is very thin and a weak area. So that is the most common site where you could have the CSF leak from. Correct. Now, if I ask you in CSF rhinorrhea, what is the most common cause of CSF leak? What will your answer be? Go on answering this in the chat box. We have understood the most common site, which is the cribriform plate of the ethmoid. If I ask you what is the investigation of choice for diagnosing CSF rhinorrhea, how would you identify the defect? And then how would you identify an active leak? If I ask you all these questions, let me see. Yes, most common cause is trauma. Spontaneous CSF leaks are accounting only 5%. Trauma is 95%. Spontaneous occurs whenever there is an increased intracranial pressure. That's because of various other causes, because of idiopathic intracranial hypertension, because of tumors, all of that. Now, what is the investigation of choice? Very good. It is beta 2 transferrin. And if beta 2 transferrin is not there in your options, then go for beta trace protein, right? So beta 2 transferrin or beta trace protein. What is the, how do you identify the defect? Investigation of choice to identify the defect is a CT scan. To identify actively, now CT can show you multiple defects, but to identify where exactly it is leaking from, what should you do? You have to do a CT cysternography. Correct? And if there is a active leak, what are we going to do? Endoscopic endonasal repair of the defect. Okay, so endoscopic endonasal repair. Very, very rarely we might have to do an intracranial approach, but most commonly we'll do an endoscopic repair. Yes. Now, for unilateral choanal atresia, which of the following is the most appropriate form of treatment? A saline nasal spray and close monitoring for any signs of respiratory distress, surgery immediately, corticosteroids, or antihistamines? Yes, I'm waiting for your answer. Which is the most appropriate treatment? See, they're asking you for unilateral choanal atresia. So if I ask you which one will present to you with an emergency, which type of choanal atresia, what will your answer be? Unilateral or bilateral? Bilateral atresia will present to you as an emergency because the child is unable to breathe at birth, correct? So what will they present to you? They will present to you with cyclical cyanosis. What is cyclical cyanosis? Cyanosis at rest and disappears in crying. That we call it as cyclical cyanosis. And what is the immediate treatment that we do here? We put a McGovern nipple and we do a tracheostomy. After doing tracheostomy, we wait for 1 to 1.5 years and then we do the repair. Correct? All of you remember this? But unilateral atresia, is it an emergency or not an emergency? It's not an emergency because one nose is blocked, the other nose is still patent for air to go in. So it doesn't present to you as an emergency. But because one choana is blocked, the nasal secretions are not able to drain posteriorly. They drain anteriorly. And that constant anterior rhinorrhea is going to be a source of infection. So should you use a saline nasal spray to clear off all that nasal secretions? Yes. Should you also monitor for any signs of respiratory distress? Because if the child develops cold and there is mucus, it will block the choana and the child will go to respiratory distress. So you should give a saline nasal spray. Because this is not an emergency, should you immediately operate on this patient? No. No need for surgery. Corticosteroids and antihistamines have absolutely no role in this disease. Now, if I ask you what is choanal atresia associated with, which syndrome? Can you all answer in the chat box which syndrome is associated with choanal atresia? I'm waiting for your answers. No, it's not Vactal, it is charge syndrome. Can you all elaborate what is C, what is H, what is A, R, E, and G and D? It's very important because they can ask you this question. What does charge syndrome stand for? C stands for Coloboma iridis. H stands for heart defects. It could be ASD, it could be VSD, all of that. A is for atresia, choanal atresia. R is not renal. Please remember, R is not renal. R is for retardation. G is for genital abnormalities and E is not esophageal but it is ear abnormality. So make a note that R and E you might get confused. R is not renal anomalies and E is not esophageal abnormalities. Okay, so this is about choanal atresia, unilateral, bilateral, all of them are done. Now let's go to the next question. So we have a patient who suffered facial trauma after RTA and he complains of a nasal swelling and bleeding. On examination, there's a pinkish blue mass on either side of the septum. Which of the following is an acute complication of this condition if it is left untreated? So answer in the chat box. What do you think is the answer? Yes. Good evening, Achan Khan. Yes. So we are seeing here that there is a patient who's had a history of trauma and there is a pinkish blue mass on either side of septum. So we are talking about septal hematoma. So if a septal hematoma is left untreated, what can it result in? It can result in a septal abscess. And if the abscess will cause infection of the underlying cartilage, there will be cartilage necrosis. And if there is a cartilage necrosis, there will be a deformity, which we call it as saddle nose deformity. So this is one of the acute complications if it is left untreated. What is the other complication which is very dangerous? If you leave it untreated, it can also go via the dangerous triangle to the cavernous sinus to cause cavernous sinus thrombosis. Yes. So these are the complications that you can see. Yes, acute complication. What is the definition of acute? If there is a disease or a complication that happens in less than 4 weeks' time. So if there is a hematoma today, you have to drain it today or maximum by tomorrow. What will happen by day after or 2-3 days later? It will get infected to form an abscess. And if there is an abscess, the cartilage will undergo necrosis, and by week 1 or week 2 end, you will have a deformity. So you get it? Medical yatri, I hope you got it. Yes, septal perforation can also occur because of the necrosis of the cartilage, but the complication that is very dangerous is cavernous sinus thrombosis that we are worried about. Okay. In a classical case of Meniere's disease, which of the following statements is true? So quickly answer in the chat box. This is very, very easy question. Gerhardt's notch is characteristic feature on pure tone audiogram. Schwartz sign is usually present in the tympanic membrane. Low frequency sensory neural deafness is often seen in pure tone audiometry, and decompression of the fallopian canal is the treatment of choice. Now, very, very easy question. Kav, we have about 20-30 case scenarios for discussion, and we have images. So it will be like for another 1.5 hours that we'll have the class. Yes. So whenever we talk of Meniere's disease, characteristically, we'll see that there is a low frequency sensory neural hearing loss. Why low frequency hearing loss? If we see the inner ear, which is the narrowest turn of cochlea, is the basal turn narrowest or the apical turn narrowest? Which is the narrowest? What do we see? Which is the narrowest turn? Is it the basal turn that is narrow or the apical turn that's narrow? Of course, the apical turn is narrow. So whenever there is an increased pressure, it will affect which turn of cochlea. So whenever there is an increase in the pressure of the endolymph, it affects the apical turn first. And what is the function of the apical turn? It is responsible for identifying low frequency sounds. We have learned about the tonotopic organization of cochlea, right? High frequency sounds are heard at the basal turn and low frequency sounds are heard at the apical turn. So now because the apical turn is getting involved first, we're going to have a low frequency SNHL. Gerhardt's notch is a feature of otosclerosis, not Meniere's disease. Schwartz sign again is a feature of otosclerosis. So both of these are seen in otosclerosis. Another sign which we see in otosclerosis is paraacusis vilsi, where the patient has better hearing in noisy environment as compared to silent environment. And decompression of fallopian tube should be done for facial nerve palsy and not for Meniere's disease, right? So I hope all of you have got the understanding of low frequency SN loss. And typically on audiometry, what type of graph will we get? Upsloping, meaning hearing loss is more at lower frequency and better at higher frequency. Yes. Inspiratory stridor tends to occur whenever there is an obstruction above the level of vocal cords, at the level of vocal cords, below the level of vocal cords in the nasal airway. Quick, guys. When would you get an inspiratory stridor? There's a rule for stridor, right? Whenever there is a pathology Above the level of vocal cord, what type of stridor will the patient have? Anything above the level of vocal cord, inspiratory stridor. Any pathology in the chest and mediastinum, what type of stridor? Expiratory stridor. Any pathology here between your vocal cords at the level of glottis or subglottis or your cervical trachea. So if they give you any pathology of the vocal cord, subglottis or cervical trachea, then there will be a biphasic stridor. If the lesion is in the thoracic trachea, bronchus, alveolus, then there will be an expiratory stridor. Okay. So here, inspiratory stridor whenever there is a lesion above the level of vocal cords. Got it? A cricothyrotomy is indicated for routine airway control, emergency airway control, trauma cases which require airway control only in children only. Again, cricothyrotomy is a topic that is constantly tested in your exam. So answer this question. Do we do this routinely, cricothyrotomy? Is it done routinely? No, it's not a procedure that's done routinely. So it's not used for routine airway control. So that's wrong. Is it used in emergency airway control? Yes. Whenever there's an emergency to access the airway, no time for tracheostomy, then we do this. Trauma cases may or not require, but it's not like a mandatory thing. And children only is again wrong. In children, we can do cricothyrotomy. Again, this is a misconception that most students have, that cricothyrotomy cannot be done in children. It can be done under children of less than 10 years of age also, but there is a difference. In children, we will do a needle cricothyrotomy. In adults, we will put a proper tube, cricothyrotomy tube. In children, we do not insert a tube. We'll just put a needle and get an access to airway. So can it be done only in children? No, it can be done in children and adults, but in children, it is done with the help of needle. So I hope this is understood by all of you, that the answer is it's an emergency procedure to access the airway. So what do? We identify the cricothyroid membrane, palpate the cricothyroid membrane, and then we are going to insert the guide wire with the help of a needle into the cricothyroid membrane and check if it is in position. Then we make a stab incision at that level and insert the tube. This is called as cricothyrotomy tube. In children, we do not insert the tube. Instead, we just put the needle. That is called as needle cricothyrotomy. Okay, then comes a question. Which of the following organism most commonly causes croup? Again, a very basic question. I want you all to answer. Susugamushi, see, there's no confusion. In tracheostomy, you're opening the trachea. In cricothyrotomy, what are you doing? You're opening the cricothyroid membrane that is present between the cricoid cartilage and the thyroid cartilage. So you open that membrane and get an access to airway. Why is it done in an emergency? Because it does not have any blood vessel there, no major vascular structure there. It is easily palpable and it can be accessed very quickly. Why don't we do it routinely then? Why do we go routinely for tracheostomy instead of cricothyrotomy? Because when we do a cricothyrotomy, we can cause accidental trauma to the laryngeal cartilages, which on a long term can cause various complications. So routinely we don't do cricothyrotomy, but in an emergency, what are we looking for? We are looking for rescuing the life. We are not thinking of long-term complication. So in an emergency, we'll do cricothyrotomy when tracheostomy is not feasible. I hope you got it. In coma patients, all the patients who are in ICU, we will do a tracheostomy. Okay. Intubation maximum for a period of 7 to 10 days. Then after that, you have to do tracheostomy. Tracheostomy can be kept for days, months, and weeks also. No problem, even years. So tracheostomy is a long-term solution for airway control. Okay. So now if we look at this question, most common organism responsible for causing laryngotracheobronchitis is parainfluenza type 1 and type 2 virus. This is the most common question that we know. Influenza, H influenza is responsible for causing acute epiglottitis, which we have already discussed. In croup, we see a sign which is called as steeple sign, which I will show you with the image. Which site in the larynx is most commonly involved or affected in tuberculosis? Supraglottis, subglottis, glottis, or paraglottis? Again, a very important question. We see various signs in laryngeal tuberculosis. Can we all recall the sign and which part of the larynx is most commonly affected? Which part of the larynx is affected in tuberculosis? It is the glottis. So the first sign that we see is hyperemia or redness of the vocal cord and sluggish movement. So what is the first sign? The first sign is hyperemia and sluggish movement of vocal cord, right? Then we will see that there will be swollen arytenoids. What is this called as? Mammillated arytenoids. Then we will see that there are multiple ulcers which are there, and these ulcers are discontinuous with each other. This appearance we call it as moth-eaten appearance, also called as rat-bitten appearance. And finally, there is swelling of the epiglottis, and this we call it as turban epiglottis. So I hope all the signs of TB larynx are revised, and now you know what structure is commonly affected in TB. It is the vocal cords or the glottis. Which of the following systemic diseases that affects the larynx shows a green birefringence under polarization after being stained with Congo red? So we know this is a common question. Which one will show apple green birefringence on Congo red staining? Generally, even otherwise, if I ask you, is it blastomycosis or is it sarcoidosis or is it relapsing polychondritis or is it amyloidosis? This is very easy question. Just the systemic part of it, they've tried to integrate it in larynx. Very good, that is amyloidosis. So apple green birefringence on Congo red staining is seen in amyloidosis. There is no controversy onto this. Which structure is visible in the wall of the sphenoid sinus? Median nerve, optic nerve, maxillary nerve, or ophthalmic artery? I would like to change the question a little bit. If I ask you in the superior wall or roof, if I ask you of the sphenoid sinus, what is the structure that is visible? Yes, I'm waiting for your answers. So if we see the sphenoid sinus, the roof has a depression. This is called as sella turcica. One second, everyone. I've lost the messages coming from you. Let me just see. Yes. And this is called as sella turcica. This sella turcica houses a gland. This is called as pituitary gland, correct? And then we have got the lateral wall and floor of the sphenoid sinus. In the superior wall, in the roof, we have a nerve which goes behind the pituitary gland to form the chiasm. What is this nerve? This is your optic nerve. Correct? And then in the lateral wall, we have got the cavernous sinus. In the cavernous sinus, what are the contents? We have got the third, fourth, ophthalmic and maxillary division of the trigeminal nerve and the sixth nerve. And the floor is related to two canals. We have got the foramen rotundum above. So this is your foramen rotundum above and the Vidian canal below. So these are the two canals, foramen rotundum and the Vidian canal. So if I ask you in the roof, what is the nerve that is present? The answer is optic nerve. If I would ask you floor, then your answer would have been Vidian nerve. If I would have asked you lateral wall, it is in relation to cavernous sinus. So you could have told the maxillary division of the trigeminal nerve. So now you're getting the answer. The answer is optic nerve. The significance of Onodi cell is due to close proximity of what structure? Cribriform plate, internal carotid artery, nasofrontal recess, or the optic nerve. So again, I'm waiting for all of your answers in the chat box. Quickly answer this. Yes. So what is an Onodi cell? Is it an anterior ethmoidal cell or is it a posterior ethmoidal cell? It is a posterior ethmoidal cell extending into which sinus? It is extending into sphenoid sinus. Now, within this Onodi cell, there are two contents that could be present. The first one is optic nerve. The second one is internal carotid artery. But ma'am, both of them are there in the options. How do I choose, ma'am? Should I go for optic nerve? Should I go for carotid? The correct answer, see, both of them are the right answers, but now you have to choose the single best answer. So the single best answer would be optic nerve. If optic nerve was not there, then you could go for ICA, but if you have to choose single best answer, then the answer is going to be optic nerve. Got it? Yes. If I ask you what is agar nasi, can you all go on typing in the chat box? What is agar nasi? What is bulla ethmoidalis? And what is a Haller cell? These are all the named air cells that we have. Yes, I'm waiting for your answers. What is agar nasi? What is bulla ethmoidalis? And what is a Haller cell? Agar nasi is the anterior most ethmoidal air cell. Bulla ethmoidalis is the biggest ethmoidal air cell, and Haller cell is an infraorbital cell. So it is an ethmoidal cell in relation to floor of the orbit. Normally, the ethmoidal air cells are in relation to medial wall of the orbit. But if you have an ethmoidal cell which is in relation to floor of the orbit, we call such a cell as a Haller cell. Okay, so these are all the named cells that we have. Okay, now what is an Onodi cell? This is your Onodi cell, which is extending into the sphenoid sinus. And what nerve is there that is coming from the orbit? This is your optic nerve. So optic nerve and the ICA both can be a part of your Onodi cell. But if you had to choose the single best answer, then that will be your optic nerve. In which of the following allergic fungal, all of the following may be seen in allergic fungal sinusitis except allergic mucin, IgE, Charcot-Leyden crystals, granulation tissue. So I'm waiting for your answers again here in the chat box. So whenever we talk of allergic fungal rhinosinusitis, there is a criteria by Bent and Kuhn, and there is a major and a minor component to it. So in the major component, whenever we say allergy, what should be positive? IgE levels should be elevated, then only we say it is allergic. Whenever I say fungal, what should be positive? KOH stain should be positive. Whenever I say rhinosinusitis, there should be some allergic mucin, which is the feature. And along with that, what do we see? We see some nasal polyposis. And we saw one radiological sign. What was that? Double density. So these five features, IgE elevated, KOH mount, allergic mucin, nasal polyposis, and double density on CT scan are major features of allergic fungal sinusitis. Charcot-Leyden crystals may be seen, but it's not a major criteria, it's a minor criteria. So all the three are seen. Granulation tissue is not a feature of AFRS. So answer is option D, which none of you have given. So the correct answer is option D. All of the following features are seen except is the question. So the correct answer is option D. Now let's go to the next question. Juvenile nasopharyngeal angiofibroma is classically associated with all of the following except epistaxis, nasal obstruction, retrobulbar pain, adolescent boys. So quickly answer in the chat box. What do you think? Yes, we know angiofibroma is seen in juvenile age group, and it is a tumor that is exclusive to males because it is dependent on testosterone for its growth. It presents to you with epistaxis and nasal obstruction. What is not a feature is retrobulbar pain. Now in JNA, if I ask you what is the most common site of origin, can you all answer in the chat box? What are the three presenting features? How do we classify the symptoms of JNA? Number three, on histopathology, what layer is absent? So HPEE will show you what layer is absent. Number four, is it invasive or non-invasive? You can go on answering in the chat box. I'll put up my questions here. Then, what is the investigation of choice? What are the signs we see in JNA on radiology? Do we do angiography? And if we do, what is the most common feeder? And what is the treatment? These are the mandatory questions you should know for GNA. So the most common site of origin is spinopalatine foramen, and this spinopalatine foramen is located about 8 to 10 mm behind the middle turbinate near the posterior wall of maxillary sinus. The three presenting symptoms are, the first one, it can cause epistaxis or bleeding manifestation, which is recurrent, unprovoked, and profuse. It can cause obstructive features where there is nasal obstruction, eustachian tubal obstruction, and it can cause cranial nerve palsies, third, fourth, fifth, sixth cranial nerve palsies. So 2, 3, 4, 5, and sixth cranial nerves are involved. On histopathology, the smooth muscle layer is absent, or the muscularis layer is absent. It is a locally invasive lesion, even though it is benign. The investigation of choice is going to be a contrast enhanced CT scan. On contrast enhanced CT scan, you're going to see anterior bowing of posterior wall of maxillary sinus, and that sign we call it as Hallman-Miller sign. So what is it called as? Hallman-Miller sign. We also see another sign where there is anterior bowing of posterior wall of maxillary sinus. Such a sign is called as Hondiusa's sign. On angiography, what will you see? On angiography, we'll see the feeding vessel of the tumor, which is most commonly the internal maxillary artery. And what is the treatment? It is embolization followed by surgical excision. So you do embolization and then you will go for surgery. Right? So this is about your JNA revision. I hope all of you have understood this, because JNA is very, very important topic. You could expect one question coming in from here. Okay, which of the following arteries arise from the internal carotid artery? Is it the infraorbital, spinopalatine, anterior ethmoidal, or greater palatine artery? Quick, quick, quick. Very good. I see all of you have answered this well about JNA. So we know that the nose is supplied by two main arteries. The upper half of the nose receives its main blood supply from ICA circulation. Lower half gets it from ECA circulation. So ICA gives rise to ophthalmic artery. Ophthalmic artery divides into two arteries, which are the two: anterior ethmoidal and posterior ethmoidal artery. External carotid artery divides into two branches: the facial artery and internal maxillary artery. The facial artery gives rise to a branch which is above the lip. This is called as superior labial artery. Internal maxillary artery divides into spinopalatine artery and greater palatine artery, both of which supply the posterior-inferior portion of the septum. So when they've asked you which of the following is the branch of the internal carotid, your answer has to be anterior ethmoidal. Now I'll ask you, there is a anastomosis that is happening at the antero-inferior portion of the septum where all the arteries will meet. What is this called as? What is this anastomosis area called as? Very good. Little's area, also called as Kieselbach's plexus. And any bleeding from here is responsible for anterior epistaxis. Which of them is not a part of the Kieselbach's plexus? Which artery is not a part of the Kieselbach's plexus? It is your posterior ethmoidal artery, which does not contribute to the Kieselbach's plexus. Similarly, we have a venous plexus located behind at the posterior end of inferior turbinate. What is it called as? Yes, it's called as Woodruff's plexus. So Woodruff's plexus is located at the posterior end of inferior turbinate, and any bleeding from there will result in posterior epistaxis. Now let's go to the next question. A 7-year-old child has peritonsillar abscess and presents to you with trismus. The best treatment is immediately drain the abscess orally, drain externally, systemic antibiotic up to 48 hours, and then drain it, or tracheostomy. So the patient is already having an abscess. Child is having trismus, difficulty in opening the mouth. Do you want to wait for the antibiotics to be given and then you are going to do the drainage? No. Do you want to do an external drainage or you want to go transorally and drain? Of course, transorally. And is there a need for tracheostomy in a peritonsillar abscess? Very rarely, if it is going to parapharyngeal and retropharyngeal spaces also, but most often it doesn't require any tracheostomy. So immediate drainage of the abscess is the best treatment for quinsy or peritonsillar abscess. Now, where do we do the drainage? We take two imaginary lines. The first imaginary line is a line passing through the base of the uvula. Right? So this is the base of the uvula. The second imaginary line goes through your anterior pillar. So just at above the point of intersection of these lines, we are going to do the incision and drainage. So where will we do the incision and drainage? Just above the point of intersection of these two lines. I hope you got it. So, Susugamushi, in a retropharyngeal abscess presenting to you with stridor, there you're going to secure the airway first. Okay? Okay. A young man met with an accident leading to loss of hearing in the right ear. On otoscopic examination, the tympanic membrane was intact. Pure-tone audiometry showed an airborne gap of 55 decibels, the right ear, with normal cochlear reserve. Which of the following will be the probable tympanometry finding? So there is an accident, hearing loss, tympanic membrane is intact, meaning there is no hole in the perforation in the tympanic membrane. There is an airborne gap. Whenever there is an airborne gap, we think of conductive hearing loss. Normal cochlear reserve means there is no sensory neural hearing loss. So after accident, if there is a conductive hearing loss, and you see that the tympanic membrane is intact, what could have been the cause? Yes, it could be because of ossicular discontinuity. And if there is an ossicular discontinuity, what type of graph will you get? You'll get a D type of graph, correct? It's actually AD, which is given in the option D. Got it? Very good. Okay, let's just do the revision. Where would you get A? It is seen in normal. AS is seen in otosclerosis or tympanosclerosis. AD is seen in discontinuity of ossicles. B type of graph is seen whenever you have a fluid in the middle ear, and C type of graph whenever there is a negative pressure in the middle ear. So I hope everyone is clear about tympanometric findings. Yes. Which of the following carcinomas have best prognosis or better prognosis? Very easy question. Supraglottic, glottic, subglottic, or epiglottic. So which of these malignancies have the best prognosis? Which will present to you early, has no lymphatic spread, and it is well differentiated squamous cell carcinoma. So what are we going to think of? This type of a presentation is seen only in glottic malignancy, so they have good prognosis. Supraglottic have worst prognosis because they present late, they have lymphatic spread to upper deep cervical nodes, and they have anaplastic variant, so it has worse prognosis. Intermediate is seen in subglottic malignancies. Okay, so I hope all of you are clear. Now, just to understand the treatment of laryngeal cancers, any patient who has primary or the first time cancer of the larynx presenting to you in stage 1 and stage 2, what should your treatment be? Write your answer in the chat box. Any patient with primary carcinoma of the larynx presenting to you with stage 3 or early 4A, what will be your treatment? Presenting to you with advanced 4A or 4B, what will be your treatment? Just 1 second. Yes, so there was a little call from hospital, so I had to take it. We were discussing the treatments, right? So if there is a patient who presents to you with stage 1 and stage 2 disease, what are we going to do? We are going to give RT. What is the exception to this rule? If there is a carcinoma of middle third of the vocal cord, then we are going to do microlaryngeal surgery. Okay, if a patient comes to you with stage 3 or early 4A, then you're going to do chemo RT. And if the patient comes to you with 4A or 4B, then you're going to do a total laryngectomy. If there is a patient in 3 or 4 who cannot tolerate chemo, cannot take chemo, then you're going to do a total laryngectomy in these patients. So I hope all of you have understood this. This is just a brief explanation. There is more detailed explanation given on my videos there in RR or in the main videos. Just go through it. That will be helpful for you whenever talking of laryngeal cancers. Now we have just cases. I want you all to just type your answers. There is no prompt given to you as options. Whenever you hear the case, you should be able to get to the diagnosis. And this is what I'm going to train you in the next 10, 12 MCQs, not MCQs, cases discussion, where I will give you the case and you have to tell me what is your diagnosis. There is no clue for you in the options below to see, is this the answer? Is this the answer? Should I rule out? No. These cases, as soon as you see the history, you should know your diagnosis even without looking at the options. So with that intent, let's begin the first question, where a 10-year-old child is having mucopurulent otorrhea for the last 4 years, meaning it's a chronic disease. And the child became dizzy with a whirling sensation, nausea, vomiting, and nystagmus to the opposite side. And then his deafness became complete and temperature was normal. 3 days later, he became feverish, irritable, and continuously crying, apparently from severe headache. Also, he had some neck retraction. The child was not managed well and died by the end of the week. What are they discussing here? What do you think is the answer here? I'm waiting for your answers. What do you think is the answer in this patient? See, whenever there is a child or a patient who has a 4 year history of mucopurulent ear discharge, are we thinking about chronic suppurative otitis media? Yes. Now the patient is having dizziness, whirling sensation, nausea, vomiting. Does that indicate to me that the patient is probably going to a complication where the disease has spread from the middle ear to inner ear? And whenever there is an inner ear involvement, will the patient have vertigo? And will there be sensory neural hearing loss? Yes. So now I know that the patient has labyrinthitis because the patient is having vertigo and SNHL, which is given. 3 days later, the patient had become more irritable. Means, is there a further spread of the disease either through the labyrinth to the petrous apex and from there to cerebellum, or via the tegmen it has gone intracranially? And because of that, can it cause meningitis, where the patient is having fever, irritability, headache, continuously crying, and a neck retraction? If you don't manage meningitis well, can the child die by the end of the week? Yes. So this is a scenario where a patient is having CSOM progressing to labyrinthitis and from there to meningitis. So this is how you should be able to localize what symptoms are given to you in the exam. So similarly, do this for the next case scenario. See, sigmoid sinus thrombosis would not present to you with neck rigidity. Sigmoid sinus thrombosis will present to you with raised intracranial pressure for sure, but they will have this hectic picket fence type of fever. They will have this papilloedema. And of course, sigmoid sinus thrombosis patients can also die, but they'll be giving you specific signs like bluish discoloration, edema of the mastoid, that all those features will be given to you, which are not given in this question. Vertigo, hearing loss are suggestive to you of labyrinthitis. Fever, irritability, neck retraction are suggestive to you of meningitis. And we know the most common intracranial complication following CSOM or ASOM is meningitis. or an abscess. So we now are very confident that our answer is absolutely right. Yes. So here we have a 50-year-old patient who is having right earache for 2 days. Only 2 days, acute disease. Pain is severe on chewing the food. Whenever you hear the word chewing the food, you should think about a disease of the external auditory canal, which is otitis externa. Now you need to know, is this localized, is it diffuse, or is it malignant? These are the three differentials which we have to rule out as we go down. Whenever they give you any patient ear pain which increases on chewing the food, you should know your diagnosis is otitis externa. There was marked edema of the right side of the face. Pressure on the tragus was painful. So again, in otitis externa, tragal sign will be positive. There was a red small swelling arising from the anterior wall of the external auditory canal. Rhenes was positive in the right ear. The patient has given two similar attacks in the last 6 months, but less severe. So what are we talking about? Small red swelling. So is it localized or diffuse? Okay, so I'm seeing some of you have written diffuse, some of you have written malignant. First of all, is the word diabetic, elderly, immunocompromised, pseudomonas given you anywhere in the question? Anywhere is it given? No. Have they given you granulation tissue at the bony cartilaginous junction? No. So can I tell it as malignant otitis externa? They are not given, so it's not malignant otitis externa. So one is ruled out, MOA is ruled out. Now, have they given you small red swelling in the anterior wall of external auditory canal or diffuse swelling of the entire external auditory canal? It is a small red swelling only on the anterior wall. So my answer will go towards localized otitis externa and not diffuse otitis externa. And whenever there is a previous such infection, you should think of underlying condition like diabetes. So such a patient, I will get investigated for diabetes. Okay, so I hope all of you got it. This answer is folliculitis or furunculosis or localized otitis externa. So this is how you rule out your diagnosis only on the basis of history. Let's go to the next question. 6-year-old child developed severe pain in both the ears with rise of temperature after an attack of common cold. The child received medical treatment and this led to decrease in temperature and pain, and so the physician stopped the treatment. However, the mother noticed that the child did not respond to her except when she raised her voice. This decreased response remained as such for at least 2 weeks after occurrence of primary condition. What are we talking? So whenever there is a child and the child has pain, fever, and hearing loss, what are we thinking of? ASOM. For acute suppurative otitis media, what did the clinician do? He gave medical treatment, which is usually antibiotics, nasal decongestants, etc. And we've seen these symptoms are increasing after URTI, again suggests to us ASOM. Now, if the physician stopped the therapies, he did not respond to, the physician stopped the treatment because the fever came down, the pain came down. So the physician did not give a complete course and stopped the therapy. What could have happened? ASOM could have become SOM, a sterile otitis media. And when there is SOM, there will be no pain, no fever, there will be hearing loss. So this condition which is in discussion is serous otitis media following an ASOM. Okay. For SOM, what will we do? We will wait and watch. For how long? We will wait and watch for 3 months. After 3 months also, if there is no resolution of the disease, then what are we going to do? We are doing myringotomy plus grome, and if there is any underlying cause like adenoid, then we are going to do an adenoidectomy. I hope this is clear. So these buzzwords is what I'm trying to get to you through these cases. A 3-year-old boy presented to the ENT specialist because of inability to close the right eye and deviation of the angle of mouth. So when a patient can't close the eye with deviation of angle of mouth, you know it is facial palsy. His mother reported that he had severe pain in the right ear 5 days prior to the present condition. She also added that the earache improved with antibiotic therapy. So, what are we talking? 3-year boy, facial palsy. Why would it occur? Is this a case of Bell's palsy? No. This is a patient who had ASOM. So, a child who is having earache and the child is having fever. What we think of ASOM. This was about 2 days prior. And now when ASOM was treated with medical therapy, the pain improved and the patient was all right. But can ASOM cause facial palsy in those patients where the fallopian canal is dehiscent? Yes or no? We have learned that fallopian canal is dehiscent in 50% of the patients. So if the fallopian canal is dehiscent in 50% of the patients, can it result in a seventh nerve palsy? Yes. Why not Ramsay Hunt, Leela and Clash Clans? Why not Ramsay Hunt? Have they given to you any vesicles in the area of distribution of facial nerve? And is it something that we see in a 3-year-old? But do we see ASOM, eustachian tubal diseases in a 3-year-old? Yes. Can they present to you with fever, ear pain? Yes. Can they present to you with facial palsy? Yes. This is the patient who had ASOM, following which there is facial palsy. Okay. Got it? Okay, let's go through the next case. After a car accident, a young male complained of inability to close the eye and deviation of angle of mouth to the left side, which is indicating to you facial palsy. And there was a hearing loss and a blood clot found in the right external auditory canal. 3 days later, a clear fluid appeared in the right ear that increased in amount on straining. A day later, patient was drowsy, developed fever and neck stiffness. What is happening in this patient? Can you all tell me what is happening? So Cav, right now it'll take some time, but let me just briefly tell you in lower motor neuron facial palsy versus upper motor neuron facial palsy, one very important feature is sparing of forehead. Sparing of forehead is a feature of UMN types of palsy because it gets bilateral innervation, whereas in LMN type of facial palsy, you will see that. Okay. So that's the only difference that I want to get it to you right now. But let's move to the question that is there in front of you. So facial palsy is there. Along with that, there is a blood clot in the right external auditory canal, which indicates that there is a fracture of the temporal bone. And because of that, there is a clot in the external auditory canal. And there is a facial palsy. Now, this patient developed watery fluid, clear fluid. What does that indicate? CSF otorrhea. And when there is a CSF otorrhea that is not treated well, can it progress to meningitis, which is given by fever and neck stiffness? So this patient had temporal bone fracture followed by CSF otorrhea, and now the patient was not treated, so the patient became drowsy, had fever and neck stiffness. Okay. In petrositis, we will see fifth nerve involvement, sixth nerve involvement, and persistent ear discharge, which is called as Grady-Negos syndrome. Got it, Leela? Yes. Now let's go to the next question. A 28-year-old male has been complaining of hearing loss in the left ear for last 6 years. The hearing loss was progressive in nature, accompanied by tinnitus. During last 6 months, there was swaying during walking on the left side, in change in the voice, inability to close the left eye, and deviation of angle of mouth. Otological examination shows no abnormality and corneal reflex was lost. What is your diagnosis? See, if there is hearing loss, unilateral, progressive in nature, swaying during walking, which means imbalance. So unilateral SNHL, which has been progressively worsening. Along with that, there is imbalance and vertigo. And there is also facial palsy and there is loss of corneal reflex, fifth nerve involvement. What are we talking about? We are talking about acoustic neuroma. Acoustic neuroma is a tumor that is present in the internal auditory canal. So, in the internal auditory canal, it arises from the vestibular nerve. So, after originating from the vestibular nerve, can it compress on the cochlear nerve to cause hearing loss, which is gradually progressive? Yes, because of the vestibular nerve involvement. Can they have imbalance and hearing loss? Yes. If it involves the seventh nerve, can it cause seventh nerve palsy? Yes. And if it goes medially towards the apex of the petrous bone and from there it spreads to the fifth nerve, can it cause fifth and sixth nerve involvement? Yes. And if it spreads inferiorly, will it cause ninth, 10th, and 11th nerve involvement? Yes. The question here was trying to test you whether you know unilateral SNHL with imbalance with fifth, seventh, ninth, 10th, 11th nerve. You should think about acoustic neuroma. Okay. Chalo. Let's go to the next question. A 30-year-old female has been suffering from seasonal nasal obstruction for the last few years and watery nasal discharge and attacks of sneezing accompanied with nasal obstruction. 2 weeks ago, she had an attack of common cold and she refused to take any medical treatment and later developed pain over the forehead and fever. She did not receive any treatment and recently developed headache, high fever, irritable, and could not withstand light. On examination, there was marked neck and back stiffness. So, what are we talking about? The patient had probably rhinitis because of which there was nasal obstruction and nasal discharge. Later, there was a attack of common cold that she refused to take medical treatment. Pain over the forehead and fever indicates to you frontal sinusitis. And recently, she developed severe headache with high grade fever, indicating the spread of infection from the frontal sinus to the frontal lobe, causing meningitis, where the patient could not withstand light and had become highly irritable with mark and neck stiffness. So, this is a case scenario where a rhinitis or a sinusitis patient has progressed to a meningitis. So remember, scenarios will not be just talking to you about diagnosis primary, they can also talk to you of diagnosis that could be related to the complications. Okay. A 52-year-old patient developed right-sided progressively increasing nasal obstruction. Along with that, there's a blood-tinged nasal discharge and there is loosening of the right second upper premolar tooth. Patient consulted a dentist who advised extraction, and that resulted in an oroantral fistula. On examination, there was a firm, tender swelling in the right upper neck. So, what are we talking about? There is a patient that there is an increased nasal obstruction. Normally, do we get blood tinged nasal discharge, or should we think of CA or inverted papilloma when we think of blood stain discharge? Loosening of the tooth again indicates to you possibility of CA. Firm tender swelling of upper neck indicates to you lymphadenopathy. So this is a patient who's having probably a nasal sinonasal malignancy. So sinonasal malignancy will present to you with obstruction, blood stain discharge. If there is a maxillary sinus cancer, there will be loosening of the teeth and oroantral fistula. So now we can localize it as a maxillary CA. And on examination, firm non-tender lymph node again suggests to you, firm lymph node suggests to you that there is a lymph nodal spread. NPC Trotter's triad is a different presentation. We're not talking about that at the moment. Okay, so we'll come back to these cases in a while. There are about 7-8 cases more, but we'll do some MCQs and come back to this. A 5-year-old patient is scheduled for tonsillectomy. On the day of surgery, he had running nose, temperature, and dry cough. Which of the following is the most appropriate next step in the decision for surgery? Again, this is a PYQ. You proceed with the surgery should be cancelled. You proceed for surgery if the chest is clear and there is no history of asthma. Should you get an X-ray before proceeding for surgery? Cancel for 3 weeks and ask the patient to come and be on antibiotic. What should you do? See, when you're doing an elective procedure, tonsillectomy is an elective procedure, and if a patient on the day of elective procedure has any infection like URTI or any form of infection with high grade temperature, runny nose, and a cough, you're not going to do the surgery because it's not imperative, it's not mandatory that you do during a time of infection, and that's a contraindication for surgery. So, what should you do? You should cancel the surgery, put the patient on antibiotics, come after 3 to 4 weeks, and then you proceed for surgery. There is no role of doing chest x-ray before after the procedure, and there's no point in doing that. If there is an active URTI, you don't go ahead with an elective procedure. That's the thumb rule. Okay. A male patient was diagnosed with maxillary sinus carcinoma of the nasal cavity, and the patient's prognosis was determined using Lederman's classification. According to this classification, which of the following may indicate a good prognosis? Alveolar process, maxillary part of the nose, ethmoid sinus, olfactory area of the nose. So you have to tell me which one will give you a good prognosis. So what is Lederman's classification? You should know. So Lederman's classification basically involves two vertical lines that we draw imaginarily from the medial canthus of the eye, two horizontal lines, one from the floor of the orbit and one from the floor of maxilla. Lower the malignancy, better is the prognosis. Higher the malignancy, worse is the prognosis. Now, alveolar process malignancies will be present where? Here, right? This is your alveolar process. Maxillary part of the nose. This is the area where you will have the maxillary part of nose. This is the area where you would have the ethmoid sinuses. And this is the area where you will have the olfactory cleft. So which one will have good prognosis? Alveolar process, maxillary or ethmoid or olfactory? Now you look at it and tell. Yes, now all of you are right. You're giving me the right answer. So it is A, the alveolar process. Lower the malignancy, better. If the same thing they would have asked you which one will have worse prognosis, then your answer would be olfactory area of the nose. Got it? We have another line which is called as Ongren's line, which is drawn from the medial canthus to angle of mandible. Higher the malignancy, worse the prognosis. Lower the malignancy, better is the prognosis. Right. Let's go to the next question. A female presented to you with decreased ability to smell, and on examination, there's a large nasal cavity with a foul smell coming from the nose. CBC is showing to you anemia and vitamin D deficiency. There is a nutritional deficiency also. What is the most likely organism responsible for her disorder? Whenever you see this condition, merciful anosmia, whenever you see that there is a wide roomy nasal cavity, what should your answer be? Yes, they're talking to you about atrophic rhinitis. And in atrophic rhinitis, do you see this caused because of nutritional deficiency like anemia and low vitamin D levels? Yes. What is the organism responsible for this? It is Klebsiella oziana. Very good. Most of you have given me the right answer. It is Klebsiella oziana. The mnemonic to remember here is hernia, where H stands for hereditary, E stands for endocrinological causes, R is for racial, N is for nutritional, I is for infective, and A is for autoimmune. So have they given you nutritional deficiency like vitamin D levels deficiency in your question? Yes. Which organism is infective? Klebsiella oziana, also called as Perry's bacillus. So the answer is Klebsiella oziana. Okay. Before we finish that question, can you tell me what are the constituents of alkaline nasal douching solution? This is an MCQ, so I'm asking you what are the constituents of alkaline nasal douching solution? And what are the surgeries that we do here in atrophic rhinitis? So alkaline nasal douching solution consists of sodium chloride, sodium bicarbonate, and sodium biborate, which is mixed with water. The surgical treatment of choice is Young's operation, modified Young's operation, and Lawton-Slager's operation. Right? So these are the surgeries that we do for patients with atrophic rhinitis. Okay. A 20-year-old male with severe congestion inside the left side of the nose has history of recurrent congestion and abuse of over-the-counter nasal decongestants. What are we talking about? This history is talking to about which condition? Rhinitis medicamentosa. Very, very good. In rhinitis medicamentosa, what should be done? Should you give intranasal antihistamine, stronger decongestant drops, intranasal corticosteroids, continue decongestant spray? What should you do? Yes. So because this patient is having rhinitis medicamentosa, we know that we have to stop the drug, which is xylometazoline and oxymetazoline, which are the abusive agents. And now because the patient will have rebound congestion, we have to give intranasal corticosteroids. There is no role of decongestant sprays or antihistamine spray. If necessary, we can add a short course of systemic steroid. Okay, so intranasal corticosteroids are given. Let's go to the next question. A patient with a history of recurrent tonsillitis underwent tonsillectomy and the patient had secondary hemorrhage post-tonsillectomy. When is this complication seen? 6 hours after surgery, 24 hours after surgery, 6 days after surgery, 14 days after surgery. So ideally, B and C both should be the right answer. Whenever we say secondary hemorrhage, it is anything that happens after 24 hours up to 14 days. So you can take both B and C as the right answer. 6 hours after surgery is primary hemorrhage. And 14 days after surgery, we don't say anything like that. And 6 hours after surgery is reactionary hemorrhage. And any hemorrhage that happens intraoperatively, we call it as primary hemorrhage. Reactionary hemorrhage is because of slippage of ligature. And what do we do for this? You have to immediately re-explore in the operating room. Correct. And for secondary hemorrhage, it is because of infection. You can give medical treatment. If the medical treatment fails, then you're going to go for exploration. Yes. Let's go to the next question. A 60-year-old female presented with hearing loss at the left ear, ipsilateral immobility of the palate, neuralgic pain on the left side of her face. Rinne and Weber was done indicating conductive hearing loss. What is this diagnosis, which is seen in nasopharyngeal cancer? Yes, so this is called as Trotter syndrome, seen in nasopharyngeal cancer, where the patient has conductive hearing loss, fifth nerve involvement causing pain around the distribution of fifth nerve, and 10th nerve involvement causing palatal palsy. Lermois syndrome is a reverse of Meniere's or variants of Meniere, where we see that there is tinnitus, followed by sensory neural hearing loss, followed by vertigo. Ideally, we see vertigo followed by SN loss, followed by tinnitus. The reverse of it, we call it as Lermois syndrome. Okay, so next question. During routine nasal endoscopy, the clinician asks the patient to swallow and the eustachian tubal orifice is open. What is the innervation of the muscles that are responsible for this observation? Vagus and accessory, vagus and trigeminal, glossopharyngeal and vagus, hypoglossal and glossopharyngeal. What should your answer be? See, normally eustachian tube is collapsed structure. There are two muscles which help to open it, which is tensor villi palatini and levator villi palatini. So the nerves that are responsible for supplying this is going to be the fifth nerve and the 10th nerve. So option 2 is the right statement. A 65-year-old male presents to the emergency department with a 2-week history of purulent nasal discharge and facial pain. Mild maxillary tenderness is noted bilaterally. He denies any nasal obstruction or changes in the taste or smell and has no postnasal drip. Which of the following radiological features are consistent with the suspected diagnosis? So it's only 2 week history of nasal discharge, of facial pain, and there is maxillary tenderness. So what are we thinking about? Are we thinking about acute sinusitis or chronic sinusitis? Whenever there is an acute sinusitis, what do we expect to see on the X-ray or on the CT scan? Normally, the sinuses should have air inside it. If there is sinusitis, there will be some secretion. So what will we see? We'll see that there is an air level above and a fluid level below. So the answer is going to be option 2, air fluid level. Right? So that's the answer. So we've done this question. Now let's go to the signs. Now all the signs which are important in ENT, I'll be revising them very quickly over here because it's going to be quick revision before your exams. What is aqueous sign? It is a sign that we see. All these signs are seen in glomus tumor. These are clinical signs that we see. Phelps sign and salt and pepper appearance is a radiological sign that we see in patients who are having this glomus tumor. We've already discussed this, so I'm not going to go into it because we've already seen that. What is battle sign? There is bluish discoloration of mastoid seen in which patient? Bluish discoloration of mastoid seen in which patients? Whenever there is a fracture of middle cranial fossa. Correct? If you see bluish discoloration of mastoid with a history of CSOM, then you should think of Griesinger's sign. And where do you get this Griesinger's sign? In sigmoid sinus thrombosis, right? So in sigmoid sinus thrombosis, you will get this Griesinger's sign. So remember, if there is a history of trauma, if there is a history of fracture, then battle sign. If this bluish discoloration is after CSOM, then we call it as Griesinger's sign. What is Bezold's abscess? It's an abscess that happens following mastoiditis where the pus trickles in which muscle? Sternocleidomastoid muscle. There is an abscess that we call it as Bezold's abscess. Can you all quickly tell me what is Septal's abscess and what is Lux abscess, which we see in patients who are having mastoiditis? I'm waiting for all of you. Yes, Brycile is still in laryngocele. Very good, Drukmi, that's right. Brycile is the gurgling sound that we see in patients who have laryngocele, where there is dilatation of saccule, which is a part of ventricle. Bocasine is seen in Zenker's diverticulum, where we see that there is again gurgling sounds because of the sac getting filled with food. Sittelli's abscess is in digastric. So Sittelli C follows D. So Sittelli's abscess is digastric abscess. L follows M. So Lux abscess is going to be your meatal abscess. So I hope all of you have understood the various signs here. Now let's go to the radiological sign, which is called as dot sign or crescent sign. This is seen in antrochoanal polyp, where there is an air shadow between the polyp and the posterior pharyngeal wall. Furstenberg sign is there is increase in the size of swelling on increasing the intracranial pressure. How do we increase the intracranial pressure? By compressing the jugular. That sign is called as Furstenberg sign, which is positive in children who have meningocele or meningoencephalocele. So you compress the jugular, the intracranial pressure will increase. That will get transmitted to the meningocele and it will increase in size. We've already seen Griesinger's sign, which is a bluish discoloration of mastoid following sigmoid sinus thrombosis. Halo sign is seen. Again, this is an important PYQ. Halo sign is seen in traumatic CSF rhinorrhea, where there is a central red dot surrounded by peripheral halo. That is called as target sign, also called as halo sign, also called as double ring sign. All of that would mean the same. Handkerchief sign in CSF leak, there will be no stiffening of handkerchief, but if there's a normal nasal discharge, you will see that there is a stiffening of the handkerchief. What is Hitzelberger sign? It is a sign that we see in acoustic neuroma. So what is Hitzelberger sign? We see that there is loss of sensation in the region of concha. So that loss of sensation in the region of concha is called as Hitzelberger sign because of involvement of sensory division of the facial nerve. It supplies the region of concha. Tolman-Miller sign or antral sign. This is seen in juvenile nasopharyngeal angiofibroma. We have discussed this. Hondius's sign is also seen in JNA where there is increase in the distance between the maxilla and the mandible. Hennebert's sign is false positive fistula test, meaning there is no communication between the middle ear and inner ear. So between the middle ear and inner ear, there is no communication or fistula, but the test is positive. This we call it as Hennebert sign, which is seen in patients with congenital syphilis. It can be seen in some patients of Meniere's disease as well. Irwin-Moore sign is seen in patients with chronic tonsillitis. What do you see in chronic tonsillitis? You will see that because of chronic infection of the tonsil, whenever you apply pressure on the crypt of the tonsil, there will be oozing of pus. That sign we call it as Irwin-Moore sign, which is seen in chronic tonsillitis, which is seen specifically in the chronic fibroid type of tonsillitis. So where do we see this? Chronic fibroid type of tonsillitis. I'm waiting for your answers. If this is all going well with you, let me know. Yes. I'm waiting for your answers. Is it all okay so far? The signs in ENT? Yes. The last one is Lodger's sign. Lodger's sign is basically whenever there is a trauma, there could be blood accumulation behind the eardrum. That is called as behind the tympanic membrane. You see that there is accumulation of blood. That we call it as Lodger's sign. Next sign is your lighthouse sign, which is seen in ASOM and in patients with acute mastoiditis, where you see that there is pulsatile otorrhea that reflects light. That is called as lighthouse sign, which is seen in patients with ASOM and mastoiditis. The specific sign for mastoiditis is going to be reservoir sign. Liar sign is seen on X-ray where you see that there is playing of carotid. And where do we see this? This is seen in carotid body tumor. Very good. Okay, omega sign is seen in omega shaped epiglottis is seen in omega shaped epiglottis is seen in laryngomalacia, which is the most common congenital anomaly of larynx presenting to you at birth with inspiratory stridor that worsens on crying. Yes. Schwartz sign is flamingo pink appearance of the promontory, which is seen through the intact tympanic membrane. And what does that indicate? It indicates to you otosclerosis. Which type of otosclerosis? Active otosclerosis. And steeple sign is a sign where you see narrowing of the subglottis resembling the steeple of the church. This is seen in group. Teardrop sign is a sign where you see in fracture of the floor of orbit, which is called as blowout fracture, where the orbital contents herniate into the maxillary sinus, giving rise to the teardrop sign. Thumb sign is a sign which you see in acute epiglottitis, and teapot sign is a sign that you see in CSF leak, where when you bend the patient forward, there is a gush of CSF that is seen in CSF rhinorrhea. Okay. Now look at this incision. We are seeing that there is an incision beginning in the incisura terminalis, going in the external auditory canal, and then at the bony cartilaginous junction. What is this incision called as? This is called as Lempert's end oral incision. Okay, it is used for end oral approach to the middle ear. If you see there is an incision made behind the ear, about 1 centimeter behind the retroauricular groove, starting from the helix up to the tip of the mastoid. What will we call this as? We will call this as Sir William Wilde's post-oral incision. So end oral incision you have seen, this is your post-oral incision. Okay, now look at this incision which is starting from 12 o'clock position to 6 o'clock position, about 6 to 8 mm behind the annulus. This is called as Rosen's endomeatal incision. So end oral is Lempert's, post oral is Sir William Wilde's, and Rosen's is your endomeatal incision. Okay, so we now know the 3 incisions in the ear. If you look at this, what type of mastoidectomy has been done? This is your external auditory canal leading to the middle ear, and this is your mastoid where you see the lateral canal, superior canal, posterior canal, sigmoid sinus, tegmen. But what do you see? Is the canal wall up or the facial nerve exposed and the canal wall has been removed? Is this canal wall up or canal wall down? Medical 3. Quick, you have to see and understand. What is it that you see? Look at this. This is the facial nerve. It's coming from the inner ear to the medial wall of the middle ear to form the first genu. This is your first genu of the facial nerve. Then it is running horizontally. Then it is going from the medial wall to the posterior wall to form the second genu. Correct? So what surgery has been done here? Canal wall up or canal wall down? Yes, this is canal wall down surgery, also called as modified radical mastoidectomy. And whenever you do this MRM, this MCQ has come. What surgery should you do? You have to widen the external auditory meatus, which is called as meatoplasty. So meatoplasty is done for all patients with MRM where you widen the external auditory meatus. Now look at this. What is this sign where you see that there is an ironed out appearance of the mastoid? Where do we get this? Where do we get this? And this is the first sign of acute mastoiditis. What sign do we see in both mastoiditis and ASOM? It is your lighthouse sign, which is pulsatile otorrhea, reflecting light. The specific sign for mastoiditis is going to be reservoir sign. The first sign is ironed out appearance. Look at this and tell me there is a red reflex coming from the floor of the middle ear. What will you call this as? Rising sun. So whenever you see the image based, you should directly know what your diagnosis is. You cannot think about the options. Rising sun appearance is seen in glomus jugulare. Very, very good. Now look at this. This is a contrast enhanced MRI where you see that there is a tumor coming from the internal auditory canal and going towards the brainstem and the cerebellum, giving rise to this appearance which is called as ice cream cone appearance, seen in which condition? Acoustic neuroma. Very good. Or vestibular schwannoma. Bilateral acoustic neuroma you see in neurofibromatosis type 2, but this is unilateral, so it is not a neurofibromatosis type 2. Now look at this image. You see something called as a delta sign. So the presence of delta sign should prompt you to what? Delta sign is a radiological sign seen on contrast enhanced CT or a contrast enhanced MRI of a patient who has sigmoid sinus thrombosis or lateral sinus thrombosis. So this is your sigmoid sinus thrombosis presenting to you with delta sign. Now look at this image, which is again a CT scan. What you see here anteriorly is your carotid bulge. Can you all make out the carotid bulge? Yes. The posterior border of the mastoid has which sinus? Sigmoid sinus. Did we see that in the images too? Yes. What is drained by the sigmoid sinus? Internal jugular vein. So this is the area of internal jugular vein draining into sigmoid sinus. Now look here, there is a bone present here between the carotid and the jugular. But look at the opposite side. Is there any bone present between carotid or jugular or it's absent? It's absent. So this sign where there is erosion of bone between carotid and jugular is called as, what is it called as? It is called as Phelps sign. Yeah, so this sign is called as Phelps sign. Now, we've already discussed this is nothing but your electrocochleography. We did one MCQ in the very beginning of it, but just to revise the images, I'm just showing to you. Whenever you see that there is a distended tonsillar pillar with uvula deviated to one side, what are the two differential diagnoses? One, it could be quinsy, or second, it could be a parapharyngeal abscess, correct? In quinsy, will there be any neck swelling? No, there will be no neck swelling. But in the parapharyngeal abscess, will there be neck swelling? Yes, neck swelling will be present. So this is how you differentiate peritonsillar abscess and parapharyngeal abscess whenever you get a unilateral bulge of tonsil with uvula being shifted to the opposite side. If you see a bulge behind the posterior pillar, so this is your uvula, sorry, this is your anterior pillar, uvula, this is your posterior pillar. Behind the posterior pillar, you're able to see that there is an abscess. So what is this abscess behind the posterior pillar? It is post-styloid parapharyngeal abscess. Pre-styloid parapharyngeal abscess will present to you as a tonsillar bulge, but post-styloid parapharyngeal abscess will present to you as a bulge behind the tonsil. So if you see a bulge behind the tonsil, behind the posterior pillar, it is the post-styloid compartment of the parapharyngeal space. If you see a tonsillar bulge like this, then it is the pre-styloid compartment of the parapharyngeal space. So if you see an abscess behind, it's from the post-styloid compartment. I hope all of you got it. And the treatment will be to do a drainage. Now, what is this? You see an air-filled swelling on the side of the larynx. So this is your larynx and an air-filled swelling on the side of the larynx because of dilatation of saccule, or which is a part of the ventricle, seen in patients who are trumpet blowers, glass blowers, weightlifters, which if increases can cause obstruction of the airway, and this can be internal, external, or mixed type. What are we talking about? Very, very good. This is nothing but laryngocele. Very good. So this condition is laryngocele. What is this condition? Where there is hypertrophy of the sebaceous gland seen in elderly, diabetics, following acne, rosacea, where we do laser debridement of the tissue. What do we call this as? This is called as rhinophyma. Very good. So that's your rhinophyma. Look at this image where there is black necrotic tissue on the dorsum of the nose seen in diabetics or immunosuppressed. Following COVID, we saw this, and this has to be treated with amphotericin B, and that requires debridement of the tissue. This fungus is angioinvasive. What are we talking about? Yes, very good. This is nothing but mucormycosis. So you have to give liposomal form of amphotericin B, and you have to debride all the dead tissue, and that will be the treatment for mucormycosis. Now look at this incision. This incision is beginning from the lower eyelid, going to the medial canthus, ala of the nose, and then to the philtrum and upper lip. And here we will remove in this surgery the maxilla, lateral wall of the nose, ethmoid sinus, the entire eyeball, and the ipsilateral palate. What is this surgery? This is total maxillectomy. And what is the name of the incision? This is called as Weber-Ferguson's incision. What is this incision called as? Weber-Ferguson incision. If they would have given you an incision like this, which is starting from the medial end of the eyebrow going up to the ala of the nose, what will we call this as? We will call this as Lynch-Howard incision. Okay, so this is your Lynch-Howard, which is used for external frontoethmoidectomy, meaning external approach to frontal sinus and ethmoid sinus. For maxillary sinus, we can go either via Caldwell-Luck through the sublabial route, and if you want to do total maxillectomy, we can do a Weber-Ferguson's incision. Yes. So this incision which I just now discussed is which incision? This is your Lynch-Howard incision, which is used for what? External approach to frontal and the ethmoid sinuses. Yes. Now let's look at the image. Can you tell me what is this cell, the anterior most or the first ethmoidal air cell? What will we call it as? Agar nasi. Again, an image-based question has come in INI where they have marked this and structure and asked you what is this cell. It will be your agar nasi. If they mark a big ethmoidal air cell, then what will your answer be? Bulla ethmoidalis. If they mark a posterior ethmoidal cell going into sphenoid sinus like this, what will be the name of that cell? It will be your Onodi cell. So now you know it. Now, what is this image? There is a foreign body in the external auditory canal. So, if they give you something like this, it is the foreign body in the canal, which is usually seen in children, presents to you with a foul smelling ear discharge, and you have to remove the foreign body. There are various ways of removing the foreign body with the help of forceps, with the help of syringing, with the help of suction, depending upon the type of the foreign body. Now, most common cause of hearing loss in adults is because of what? It is because of ear wax. And if they give you this image where you see this brownish color plug in the external auditory canal, then it is a wax, which is the most common cause of hearing loss. This we have seen where you see that there is accumulation of desquamated epithelium, one layer over another layer over another layer. What do we call this as? This is called as keratosis obturans because of ciliary motility defect with this accumulation of keratin where one layer over another layer results in pain and hearing loss. It could be associated with other ciliary motility disorders. What is this procedure where they're using this syringe, which is called as Simpson's oral syringe? So this Simpson's oral syringe is used for doing syringing, where we remove the wax or foreign body. The water has to be of body temperature. If you use anything above or below, it can cause caloric reaction. The patient can have vertigo, and you should direct it towards the posterior superior canal wall. And if there is a perforation of the tympanic membrane, then it is contraindicated. So these are the things that you should know for syringing. Now look at this. The instrument that has been used here is otoscope, and the procedure is called as otoscopy. This gives approximately 2.5x magnification. We can visualize this in the we can visualize the external auditory canal and tympanic membrane, and because it is portable, I can take it everywhere in the ward or wherever I go to visualize the tympanic membrane. Now look at this. You see a small pit or a sinus at the preauricular area. This happens because of the incomplete fusion of tubercles of His. This is a preauricular sinus. Okay, so this normal preauricular sinus, if it doesn't get infected, there's nothing that you have to do. But if it gets infected, then you have to do complete excision of the sinus. And if you don't do complete excision, it will result in recurrence. What is this condition where you see blackish spores with a whitish discharge? Where do you get this? This is otomycosis. The cardinal feature of otomycosis is itching, and the patient will have on examination a wet newspaper type of appearance, and the treatment will be topical antifungal. The organism that is most common responsible for causing this is going to be Aspergillus niger, followed by Candida, followed by Aspergillus fumigatus. Now look at this condition. There is entire canal is edematous. It is red. So is it localized otitis externa or is it diffuse otitis externa? Yes, so this is diffuse otitis externa, also called as swimmer's ear, also called as Singapore ear. This condition happens because of excessive moisture that enters into the canal, converting acidic pH to alkaline. The main symptom will be pain, discharge, and this will increase on chewing. These words will be used, and then on examination, the entire canal is edematous, talks to you about diffuse otitis externa. Look at this condition. There is whitish keratin flakes. And along with the whitened keratin flakes, you're seeing some granulation tissue also of the tympanic membrane. So what is this? This is the patient who has acquired cholesteatoma. So very important, an image-based question showing to you some attic retraction, posterior superior quadrant per retraction with keratin flakes with granulation should prompt you for an unsafe disease or an acquired cholesteatoma. Look at this condition. There is a perforation in the pars tensa. Whenever you have a perforation in the pars tensa, which type of CSOM will you think of? Tubotympanic type of CSOM. Now look here, there is an air level above and a fluid level below. So air fluid level is a hallmark of which condition? We will get this in serous otitis media, non-suppurative otitis media. There are two important things that you should look for SOM, either the presence of air bubbles or air fluid level. If these two are present, then it is SOM, serous otitis media. The rest of them, it could be thick, thin, dull, lusterless, gray, blue, black, all of that could not be there, but two consistent features is presence of air bubbles and air fluid level. Now, what surgery has been done here? They have done a myringotomy and inserted a ventilation tube. This ventilation tube can be named as Grome. It can be called as a tympanostomy tube. Both of them mean the same. And this is done for which condition? It is done for gluear non-suppurative otitis media. Now look at this graph, bilateral downsloping. What is your answer? Bilateral downsloping type of SNHL, where AC, BC both are abnormal. This is AC, this is BC, both of them are abnormal, and bilateral SNHL. What is your answer? Very good. Presbyacusis. If the same graph instead of bilateral was unilateral SNHL, then you should have thought about even acoustic neuroma. Okay. Look at this, a 5-step maneuver where the patient is made to change position to treat vertigo. Dick Salpike was positive. What is this maneuver called as? Yes, this maneuver is called as Epley's maneuver. Correct. So this maneuver is called as Epley's maneuver, which is done for BPPV. Can you tell me what examination is being done in this patient? It is anterior rhinoscopy with which speculum? It is your Tudicum's nasal speculum. So what you're seeing here is the DNS, deviated nasal septum. Look at this X-ray, showing to you something. What is this? This is a foreign body in the nose. So whenever you have a foreign body in the nose, this is how it will appear to you on the X-ray. Look at this. Tell me what kind of tonsillitis, where there are whitish yellow dots on the surface of the tonsil. What kind of tonsillitis? The tonsil is bulging, almost occupying 75% of the airway space. Such a tonsil, we call it as grade 3 tonsil. And when there is whitish yellow dots on the surface of the tonsil, what will we call it as? Follicular tonsillitis. Very good. Now, acute or chronic, based upon the disease duration, you can identify. But for now, you know that it is a follicular type of tonsillitis. Can you tell me what is this swelling where you get a bluish translucent swelling in the floor of the mouth? What will you call this as? Yes, so this is a ranula where you see that there is a bluish translucent swelling in the floor of the mouth. This arises because of the extravasation. So it is an extravasation cyst coming from which gland? From the sublingual salivary gland. So you have to remove the ranula along with the sublingual salivary gland. Otherwise, there is a high rate of recurrence. If you would see a midline swelling, then you should think about dermoid. But if you're seeing a swelling on the lateral part of the midline, then you should think about a ranula. What is this? You see a red vascular mass in the posterior part of the nose, and on examination, you're seeing anterior bowing of the posterior wall of the maxillary sinus. What is this sign called as? This is your Hallman-Miller sign. Where do you see this? This is seen in JNA. We have revised everything about JNA in one of the MCQs before. So I hope your the image of Hallman-Miller and the picture is also sorted. Now you see that there is a polyp, red vascular mass in the nose with whitish dots on the surface, and there is sporangia with spores. This also has come as multiple times PYQ. What is it suggestive to you of? Yes, it is rhinosporidiosis caused by Rhinosporidium seaberry. And what is the mode of infection? The mode of infection is via water. It presents to you as a strawberry mass in the nose. This strawberry mass is known to bleed on touch. And the diagnosis is established on the basis of histopathology. The treatment is you have to remove the mass and cauterize the base. Dapsone is given to prevent recurrence. Okay. Now look at this image where you see that there is a mass coming probably from the maxillary sinus going posteriorly to the choana. And between the mass and the posterior pharyngeal wall, there is an air shadow. So what do you call this sign where there is an air shadow between the mass and the posterior pharyngeal wall? We call this as crescent sign, also called as dot sign. And where do we see this crescent sign or dot sign? This is seen in antrochoanal polyp. Very good. Rukmini, Miculic cells and Russell bodies are features of rhinoscleroma, not rhinosporidiosis. What we just saw was rhinosporidiosis, not rhinoscleroma. Okay. Here you're seeing that there is a deficiency of the palate. They are not meeting in the midline. Such a palate, what will you call it as? Cleft palate. And cleft palate is a contraindication for doing adenoidectomy and tonsillectomy. Now look at this palette where you see whitish fibrous bands, history of tobacco, history of smoking, history of use of, areca nut, all of that results in fibrosis. What do you call it as? Oral submucosal fibrosis. And for oral submucosal fibrosis, you're going to give injection Kenacort and hyaluronidase. This is injected into the fibrosed palate to release the adhesions. Now look at this unilateral mass, pedunculated mass occurring because of sudden voice abuse. So unilateral, pedunculated mass occurring because of sudden voice abuse, occurring at the junction of anterior 1/3 and middle 1/3. What are we talking about? We are talking about vocal polyp. Yes, so this is a patient who has vocal polyp. Bilateral nodular lesions at the same junction would be vocal nodule because of chronic voice abuse. Now, bag of water appearance. Where do you get this bag of water appearance? History of smoking, history of reflux is there. What do you think? It is seen in Rinke's edema. What is Rinke's edema? Accumulation of edematous tissue or myxomatous tissue in the Rinke space. What type of voice will they have? Low pitched voice. And what is the treatment for them? Stripping of the vocal cord. So what do you do? Stripping of the vocal cord. Look at this condition. Hypertrophic epithelium on one side, ulcer on another side. What do we call this as? We call this as pachyderma laryngitis, also called as contact ulcer, also called as kissing ulcer. Again, this happens because of excessive voice abuse, and this is not a true ulcer. This is a pseudo-ulcer. There is no actual breach in the epithelium. There is only indentation. So this is not a true ulcer. It is a pseudo-ulcer. Look at this condition, whitish plaque-like lesion on the vocal cord, history of, smoking is present, alcohol is present. What is it? This is called as keratosis larynx, also called as leukoplakia of the vocal cord. So if there is keratosis or leukoplakia, what should you do? You have to do the excision of the leukoplakic patch. It is pre-malignant. Now, coming to the instruments, what is the name of this gag? What is this gag called as, which is commonly used for tonsillectomy, adenoidectomy, or any other oropharyngeal procedure? This is called as Boyle-Davis mouth gag. Okay, there are different tongue blades, a slotted one, non-slotted one. This is your tonsillar dissector, Mollison's tonsillar dissector, and anterior pillar retractor. So this will help me dissect the tonsil from its bed. So dissector and anterior pillar retractor, we call it as Mollison's anterior pillar retractor and tonsillar dissector. Now, if you see, this is a snare which will help in crushing and cutting the tonsillar pedicle from its base. This is called as Eve's tonsillar snare. So all the instruments that you saw so far were used for tonsillectomy, the mouth gag, the snare, the tonsillar dissector. Now you see here, this is an instrument which is used for adenoidectomy. And what is the name of this instrument? This is called as St. Clair Thompson adenoidectomy curate. It has got two parts, one with cage and one without cage. So if you add this cage and you remove the big bulk of adenoids so that they don't get aspirated into the airway. In the final portion, in the last portion, when you have removed the major bulk, you will go with the one without blade, without the cage. So this guard or cage is detachable. You put it in the initial part, use it like a dagger to remove the big chunks. Once the big chunks are out, for smaller tissues, you're going to do one without cage. What is this instrument? We've just discussed. This is called as Pudicum's nasal speculum, and it is used for what procedure? It is used for anterior rhinoscopy. Now, very, very important. This is a PYQ asked multiple times. What is the name of this instrument? So if you see, there is an instrument having equal number of prongs, meaning 4 prongs on one side, 4 prongs on another side. This is called as Mollison's hemostatic mastoid retractor. If you see that there is 4 prongs on one side, 3 prongs on another side, 4 into 3, then we call it as Wheat-Lanner's retractor. Okay, so what is it called as? Wheat-Lanner's. 4 into 4 is Mollison. Reverse M, you get W. So it will be 4 into 3, which is Wheat-Lanner. If one prong is longer, it is 4 into 3, but one prong is longer. So what is happening? One prong is longer, then we call it as Plester's retractor. So one prong is longer, what do we call it as? Plester's retractor. And if you just have one prong on one side, 2 or 3 prongs on another side, such a retractor, we call it as Perkins retractor. So 1 by 3 is Perkins. So 4 by 4 Mollison, 4 by 3 is Wheat-Lanner's. One prong longer in Wheat-Lanner's, we would call it as Plester's, and Perkins is 1 by 3. So I hope all of you are clear with this mastoid retractor. If you have a retractor where instead of using the finger, see you can see here, these are the knobs to open and close the retractor with our finger. Instead of that, if you have a knob to open and close, such a retractor which will be called as Jansen's retractor. Okay? Okay, Rukmini? Last instrument which we have, this is called as Lax tongue depressor. Not Lux, it is Lax tongue depressor. Okay. And that's about it. Let me just go through the case scenarios, which I had told you, 5 or 6, which are left behind. So with this, almost all the images under ENT will be covered, radiology under the ENT will be covered, clinical images will be covered, almost all the important signs that are necessary for you to know, I have covered through the discussion of signs. And then I have given you various MCQs with clinical scenarios. I have given you only clinical based questions where you should be able to diagnose on the basis of history what is the clinical case. So we just left with last 4 or 5 clinical cases with which we will be done. So we have a 40-year-old female complaining of nasal troubles of long duration in the form of nasal obstruction, anosmia, and crusting. See, obstruction, anosmia, crusting 2 months ago. She developed mild stridor that necessitated through tracheostomy. She received medical treatment for a condition, but 1 month later, she developed severe to profound hearing loss that necessitated the use of hearing aid. So what is this diagnosis? What are we thinking about? See, if there is a patient who's having nasal obstruction, merciful anosmia, and crusting in the nose, we are going to think of atrophic rhinitis. Now, this atrophic rhinitis is caused by Klebsiella. This atrophic rhinitis can spread into the airway to cause atrophic laryngitis, where subglottis is the narrowest region that is going to get affected to cause subglottic stenosis, and that must have resulted in mild stridor. Now, because of that stridor, they did tracheostomy. Now, when she was receiving medical treatment, what are the drugs of choice which we give? Streptomycin, tetracycline, and rifampicin, plus or minus rifampicin. So when we give streptomycin, Is it an ototoxic drug? Yes. Can it result in profound hearing loss? Yes. So this is a case scenario that can really happen in patients. So now you should be able to understand that how a clinical case can progress from just atrophic rhinitis. So far you knew how to diagnose atrophic rhinitis, but from atrophic rhinitis progressing to stridor because of subglottic stenosis on streptomycin, gentamicin, all of that she's developed hearing loss and requires hearing aid should prompt you towards the right direction. Next, we have a 1 second. So next we have a question where a 24-year-old male with severe pain in the throat and left ear with sudden onset of duration. He gave a history of sore throat few days prior to the condition. On examination, the patient looked ill and thick voice. The temperature was 39 and the pulse was 110. The patient had fever of breath and unable to open the mouth. There was marked edema of the palate concealing the left tonsil that found injected. There was hot painful swelling located below the angle of mandible. The left tympanic membrane was normal. So the clinical history initially that is suggesting to you of throat pain, fever, which was of 2 days, is of suggesting to you of acute tonsillitis. Acute tonsillitis, can it progress to abscess, which is your quinsy? Yes. But from quinsy, from the peritonsillar space, can it go to parapharyngeal space where you will see that there is edema and the swelling located below the left angle of mandible? So quinsy can progress to parapharyngeal abscess. So such a case scenario of acute tonsillitis progressing to quinsy and parapharyngeal abscess is given in this patient. A 49-year-old patient presented with enlargement of upper deep cervical node since 6 months. The node appeared on the right side and later on the other side. There is a history of decreased hearing loss with nodes. What should you think of in a 49-year-old? And you think if it is associated with Epstein-Barr virus, what would your answer be? Recently, he developed diminution of hearing in left ear with nasal regurgitation, indicating cranial nerve palsies 9, 10th, and 11th. What is the answer? Is it your nasopharyngeal cancer? Yes. The reason for doing these cases is not every time will you be able to get through the diagnosis only when you have options in the front. You should be able to get through the diagnosis even without options. Okay, a 40-year-old female began to experience difficulty in swallowing for the last 3 years, the difficulty in swallowing for all kinds of food, and there was a sense of obstruction. For last 2 months, there is rapidly progressive difficulty in swallowing, even to fluids together with change of voice, and there is a non-tender swelling in the right upper neck. So whenever you have a firm non-tender swelling with the dysphagia, you have to think about cancer of the hypopharynx. Okay, why is there dysphagia? Because of mechanical obstruction. Initially, it was for solids. Later, it became even for liquids. And along with that, if there is a neck node, then you should think about CA hypopharynx. Okay. 4 hours after adenotonsillectomy, a 6-year-old boy had a pulse of 110 per minute, blood pressure of 100/70, and the child vomited 250 cc of dark fluid. 2 hours later, the child vomited 150 cc. So, what kind of hemorrhage is this if it is happening 4 hours after tonsillectomy? It is a reactionary hemorrhage. And because of that reactionary hemorrhage, this child is swallowing the blood and vomiting it out. So you have to immediately re-explore in this situation. Take the child in the operating room. A 3-year-old child suddenly developed sore throat and enlarged upper deep nodes. Later, the child developed marked body weakness and respiratory distress that became progressively severe. Oropharyngeal became severe. 2 days later, the patient developed nasal regurgitation. I think this question is incomplete. I haven't typed it, so let's give it a skip at the moment. So with this, I have finished most topics in ENT, I have tried to incorporate difficult, challenging cases for you so that you have that thought process of how to think in the exam. Just don't be stuck to one diagnosis, buzzwords and diagnosis, buzzwords and diagnosis. That's not the case every time. You have to imagine, or you have to expand your scope of understanding. And which is why I have given you the basics also. I have given you all the signs, I've given you the images, I've given you the instruments, I've given you the routine MCQs, the PYQs, but I've added everywhere some points which are necessary for you to differentiate basic questions to an advanced level question, which could be expected in your INI-CET exams. So with this, I'll take your leave. And there's one question that's coming. Why you took ENT? I'm getting opthal, ENT, and anesthesia, ma'am. What to do? It's all individual choices. I was inclined towards ENT because I didn't want to take up any subject that would involve me to give a lot of time in regards to work, like hospital work that involved emergencies, like say medicine has a lot of emergency, gynec has a lot of emergencies. So I somehow wanted to have a balance in my life where I could choose to do clinical work, but yet choose not to do emergencies. Like in ENT today, if I say I don't want to take up emergency calls, it's absolutely fine with my hospital. But yes, initial period during residency, I did have to take, but then eventually over a period of time, I can make my choices. And ENT would give me options to do both medical and surgical treatments. Like there is a good OPD, there is a good surgical options, and there is not too much of stress involved. I agree there is a lot of competition, but the stress levels are not so high. So taking all those into consideration, and because at that point of time, I was already married and my husband was a neurosurgeon, and we thought that doing ENT would help us expand the scope of work which we can do, which was skull-based surgery, and that was just evolving that time when I started to do ENT. So taking all those aspects into consideration, I chose ENT, and I was lucky enough that I had a family where my husband is a doctor, my brother-in-law, sister-in-law are doctors, my uncle, aunts in my house. We have many number of doctors, so they guided me in every branch. What is the pros and cons? And after understanding, I took PNT. So I hope that solves your doubt. High 5839. If there's anything else that I can help you with, please leave your messages in the comment section below. I will be more than happy to answer them. If not now, even later you can do that, or you can connect with me directly. That's also fine. I will be there for all of you. Wishing you all good luck. Please put up your best in the examination, and do whatever you can do in the last few days, because you're very close to the INI. See you again. Bye-bye.